May I kind of sort of introduce our next speaker? As it has been the case during the afternoon, we are changing gear. And it is a great pleasure to introduce my colleague, Professor Melanie Abbas, who has been doing some really interesting pioneering work in the integration of mental health and the treatment of people with who are HIV positive. Melanie, all over to you.
I wasn't took it that serious when I was taking my medication. I thought it was a minor issue. So sometimes I started to realize that my status was not good. And it keeps hitting me because I was the only one in the family infected. I always thought of ending my life.
It's really hard and painful. It's hard to live without your biological mother or biological father. Whilst I was in the hospital, after I was being discharged, 2 days later, I had a stroke. And the stroke, it also affected me. Because they said you get loss of memory and a loss of memory. That's where I started to know I think there's no way to live. How can I live?
Hi, good afternoon, everyone. My name is Melanie Abbas, and I wanted to start by acknowledging what a privilege it has been to be part of the Centre for Global Mental Health for the last 10 years. Now, the voices you heard of Gloria and Isaac, took part in a project where we gave phones to young people living with HIV and asked them just to record anything they might like to talk about in their daily lives. And these extracts are very typical, that they brought up the discrimination, the loneliness, and tragically often the suicidality associated with living with HIV. Now, fortunately, the rate of infection in children has been declining really dramatically over the last 20 years. But HIV remains a public health problem of huge importance. We still have 37 million people living with HIV globally, of whom 66% are living in sub-Saharan Africa. And a very worrying figure is that the rate of new infections has not declined in the last 5 years. So we're talking about 1.7 million new infections a year. And in the settings where I work in Southern Africa, the key population there is especially young women, older adolescent girls, and young adult women. And some of the social determinants that Crick and others have been talking about this morning are absolutely pertinent, that's driving this cycle of transmission, because this is poverty and trauma that's underpinning this continued epidemic in young women. And I'm not going to go into that in great detail today, but this is about transactional sex with older men, often to pay their school fees or to put some food on the table for their families. So what I want to talk about today is, where does mental health fit in to this picture? Now, for a long time, we have known about the HIV care continuum. So we know it's very important, if you're living with HIV, to be diagnosed, to be linked to care, to be prescribed antiretroviral therapy, and to achieve viral suppression. And there are two things I particularly want to say about viral suppression. If you are virally suppressed, which means that the level of virus is below a certain level, you can live a near normal life expectancy. And added to this, your risk of transmission to your sexual partners is eliminated. That's the message called U equals U. Undetectable is untransmittable. Most young people living with HIV who acquire HIV in sub-Saharan Africa don't know this message yet. We know it sitting here in the privileged parts of the world that we live in, but the people who really need to know this. And it's one of the reasons why HIV remains so stigmatized. So a couple of years ago, UNAIDS set these very ambitious targets called the 90-90-90 goals. And these are that across the world, they said by 2020, we want 90% of people living with HIV to know their status, 90% of those to be prescribed antiretroviral therapy, and of those, 90% to be virally suppressed. So the key issue, the key link between being on ART and being virally suppressed is what? Charlotte? Adherence, exactly. So, and the interesting thing, an important thing about HIV medication is you need to take it on time every day. So adherence is really critical. So depression, which is the topic I really want to talk about today in relation to HIV. Why depression? Depression is the most common mental health comorbidity with HIV. So if we think that the population prevalence of depression is around 4.5%, we're talking about 9% for people living with HIV at population level. For those using services, it's more like a quarter of people. And for those who are not virally suppressed, our own research has shown that it's about 45% of people who are not virally suppressed will meet criteria for depression, at least on screening scales, validated screening scales. What we don't know, there are some really interesting questions that the research I've been involved in over the last 8 years has been looking at. Firstly, can we improve depression symptoms for people living with HIV who are depressed? But more importantly, can we actually accelerate progress towards these 90-90-90 goals? And it's a very pertinent time to be working in this area because in 2016, for the first time, the WHO said HIV care facilities need to be screening people for depression. And UNAIDS, for the first time last year, held its first thematic meeting on HIV and mental health. And there's a real big push towards saying, you know, what can we do about this? So the Ministry of Health in Zimbabwe actually approached me and others in my team and said, okay, so what can you do to help us? If we screen, what on earth are we going to do? How do we screen? But more importantly, what do we do? So very quickly, I would just want to remind us, just talk about why we have this very high prevalence of depression in people living with HIV. A lot of the drivers that underpin depression and HIV are very similar. And these are on the right-hand side of the slide and will be very familiar to you. But also there's another link, behavioral link, which is that people with depression are less able to negotiate safe sex, which is a behavioral driver. Once you've acquired HIV, there are the biological factors, the CNS inflammation, side effects of medication, but also the huge impact of the loss and stigma-related factors that go on as part of living with the condition. So we know from research, particularly in the US, that the treatments that work for depression tend to work very similarly in terms of good outcomes for depression in people living with HIV. So if you think broadly, we've got talking therapies, we've got antidepressants, and we've got alternative treatments. So we've been trying to put this jigsaw together. So actually PEPFAR funded a piece of research which piggybacks onto the Friendship Bench. I'll just remind those of you about the Friendship Bench. So the Friendship Bench is basically a step care intervention for depression. It's based on problem-solving therapy, up to 6 sessions for people who screen positive in primary care for a common mental disorder, based on problem-solving therapy delivered by grandmother lay health workers sitting on a wooden bench in the grounds of a primary care clinic. And what the program is led by Dixon Chibanda in Zimbabwe. A number of us, including Ricardo, myself, and Helen Weiss from Centre for Global Mental Health have been very involved in this. And we demonstrated a few years ago that in a general primary care population, we saw a highly significant benefit that was only at 6-month outcome and in a cluster randomized trial. So with all those caveats, though, we did demonstrate a significantly improved outcome for the friendship bench compared to clinics where the friendship bench wasn't running. Looking within that population, 42% of that group declared that they were living with HIV, and we found that the effects of the intervention were similar. So it was encouraging that people were living with HIV, a bit like Roxanne was saying this morning about the IPV population, were doing as well as the general population. So what PEPFAR were interested in asking us to do is, could we piggyback a study of viral load suppression onto this? And we've actually got a big cohort of 750 people to see whether purely having the opportunity to interact with the friendship bench, if you're living with HIV, if that's associated with improved viral load suppression. We don't have results, I'm afraid, for you, but we should have in about 6 months. I just want to remind you about some of the domains affected for someone who does have major depression, and just want to highlight 3. So we think about the sadness, the low mood. So another way to think of this is the fact that we have dysregulation of mood, also known as negatively valenced emotions, so that people who are depressed react to things in a more negative and fearful way than people who are not clinically depressed. There are also big effects in terms of cognition, so memory, attention, concentration, and also cognitive control, which is really about executive functioning, planning, problem solving. So you can kind of probably see where I'm going with this, which is that if you have depression, it would make lots of sense that you would have particular difficulties with this key link between being placed on ART, antiretroviral therapy, and being able to achieve viral suppression. You've got to take medication every day on time, and that's very difficult for anyone, let alone someone who's depressed, and also living, as we have seen, probably given the drivers of depression and HIV, perhaps also facing a lot of other challenges, difficult life circumstances. So what we did next, but while we're waiting for these PEPFAR results, we've been working actually very hard in parallel for the last 6 years, working on an intervention that could perhaps more directly help people with depression and HIV to address their poor adherence. So we took the problem-solving therapy that is used in the friendship bench, and we said, well, given that HIV facilities, HIV care is decentralized, in Zimbabwe alone we have something like 3,000 clinics providing HIV care. What about the cadres who are already providing HIV care? Maybe they could also be trained in something like problem-solving therapy. So the first thing we did was we took this into problem-solving training and worked out whether adherence counselors, people already providing HIV care, could be trained. But then we went to the literature and found, again, based on evidence from the US and from a systematic review, which actually gives a very distorted summary of its results, which actually says, there's a systematic review by Sin and Di Matteo, which says, oh, actually, if you treat depression, you can improve adherence. But it's a highly flawed systematic review because it relies mostly on retrospective data. And actually, the studies that are most impressive from that review were the ones where they did something extra to help people change their behavior. And what we found was this really, really impressive intervention called Life Steps, which was developed by somebody called Steve Safran at Harvard, who started the Harvard Department for Behavioral Medicine. And this is an intervention for adherence, which has this triad of powerfully delivered, accurate information, education, helping people to be motivated or looking for people's motivations rather than scare tactics or, I'm afraid, the kind of bullying that sometimes goes on in primary care where people haven't taken their medication. and helps people to problem solve around their barriers. And Steve has really devoted his life to adherence interventions. And I was very, very fortunate that he was interested to come on board into our team. So we blended these two, we culturally adapted it for a low resource setting. And as somebody else said earlier on today, it takes a lot of time. So yeah, 6 years down the track, we have this nice study which we call TENDI, which stands for Treatment to Improve Depression and Adherence to Antiretroviral Medication. And it's a blended intervention, and we have published our pilot trial results, and we're now in the midst of a very large RCT. But what we learned a lot from the pilot, and I would really urge those of you who are starting or in the middle of your careers, as beginning to develop interventions, do try to get money for your feasibility studies, because you really learn a lot from them. So what was some fascinating things? So we recorded the sessions and listened to them. And that was absolutely critical. What we found was that the adherence counsellors dealt with the adherence quite quickly in the first session. I should say this is a 6-session intervention, and it's particularly targeted at people who have viral non-suppression. So this is just the group that the Ministries of Health are really, really keen to provide support for. And it's, depending on the age group, you could be talking about 70% of people living with HIV, if particularly in the younger groups are non-suppressed. And also those who miss appointments, who are so-called defaulters that we had to go and find. So that's another group that this intervention is designed for, so high-risk group. So what we found was that the adherence counsellors got so interested in the depression and the social problems that they've been, for the first time really, been talking to the clients about, that they sort of forgot the adherence. And so they focused much more on the depression. And even despite this being a pretty small pilot RCT, and we weren't powered to show differences, it was a feasibility study, we were more looking at acceptability and feasibility, we actually saw this statistically significant improvement in depression. And actually we did get quite surprising changes in viral suppression, even in a very small study. Another thing I learned is that adherence is incredibly difficult to measure. So it's very helpful to have a really hard outcome when you're working in HIV. But that's the matter of another talk. So we did get promising outcomes, and on the back of this, I was fortunate to have a very large R01 funded by the National Institute of Mental Health, and that is again an ongoing study. I'd just like to introduce you to some of our team, some of whom are here, like Barbara Barrett. So we're doing a large cost-effectiveness RCT of this program. And because we are, so I'll just say we've got a really international team. Not everybody is here. Dixon Chibanda and Prof James Hakim are also part of this trial, and Steve Safran, but we've got people from the US, from obviously a very large Zimbabwean team, and from King's in this program. And what else should I say about this? Yeah, because we're very interested, the ministry are very interested in scale up, we're also on the back of this learning about aspects like fidelity to interventions. How am I doing for time? Hi, Mary. Am I okay for time? Yeah, 5 minutes, okay. Turning to something really quite different, I think task shifting, in order to reach large groups of the population, particularly perhaps young people, people who don't use services, then we need to think of different ways to task shift. So for a while, the clinics that our team have been working in Zimbabwe said, why are you doing all this work in adults? It's adolescents that we really need you to work in, because they're the ones who don't take their medication and the ones who have really complex mental health difficulties. And I'd been resisting that because none of us were specialists in child or adolescent mental health. But in the end, they came to us and said, look, we've got a group of 20 or 30 young people in the clinic out of say this was one particular clinic with about 500 adolescents on the books who are persistently non-adherent. Their viral loads are in the hundreds and hundreds of thousands. Some of them haven't taken medication for 5 years. They're coming in with cryptococcal meningitis. Could you just do something? So we actually teamed up with a musician who had developed a syllabus for a creative arts program for children in some very disadvantaged schools in Zimbabwe. And we got a grant to run, a 6 to 8 week program, which involved using the creative arts and also blending this adherence intervention, but in groups. And to our surprise, well, for a start, another message here was that a 6-week intervention turned into a 20-week intervention. And that's something, I think, a very big message, is that if you're going to start working with young people who've experienced trauma, discrimination, abuse, who are not taking medication, you're going to have to be prepared to be in there for a bit longer. These are not going to be quick fix interventions. But this is a year follow-up. Now, again, it's a small group, but at baseline, 22% were virally suppressed. And this is a year follow-up, nearly 70% were virally suppressed. Many of them are now working, and we now have a new grant and 7 of the original group are training to become peer mentors for the next group. So this is a small study, but I just want you to hear some of their experiences.
Firstly, this group has been useful to me because I have learned the skill to meditate in this group. And secondly, I've learned to focus on one thing. If I focus, I will prosper.
I'm happy because I was such a person who used to say, better to die, because there was no option. I have no one, what am I going to do in life? And who am I? But when I came here, I see that I'm not alone. We were a lot. And I see that there is somebody who is love. We have a love, who love me, who care for us. So I'm just happy because I'm not alone.
So what we've been talking about today is the 90-90-90 goals, and I've just shown you some examples of where task-shifted, task-shared interventions, which do have the potential to be scalable, can improve with achieving the last one of these. And we've got a number of publications. We're a large team, so if you would like to tweet us, then we'd be very happy to share these. And just very briefly, what about the road ahead to scale up? And I'm really encouraged we have, because we've blended evidence-based interventions, particularly with the Tendai program, using the problem solving and the life steps adherence. We actually have an NGO, for instance, OFID. It's a country-level program that works very closely with the Ministry of Health, that really actually wants to start implementing and is looking to PEPFAR to fund this. We've had less success so far with the Global Fund, but the Clinton Health Access Initiative are also very interested in trying to secure major funds. And I just wanted to end with something that happened today. Somebody got that T-shirt. I just wanted, that T-shirt. I think someone's taken my T-shirt away. Somebody who's in this audience, who I don't need to name, gave me an incredibly special gift today. Some of you may have seen Annie Lennox and Nelson Mandela wearing a T-shirt like this. And somebody actually had found one and gave this to me, which I am incredibly touched. But I think it's also with the message that we need a message like this for mental health. We need celebrities to wear T-shirts to say, I am not ashamed say, and who knows, am I wearing this because I'm HIV positive, or am I wearing this because I want to have solidarity with people, I want to advocate? And so I think that that's a challenge to you all. I think the next competition, perhaps for the Centre for Global Health, should be about a message we can all wear on T-shirts for mental health. So thank you very much.
Thank you, Melanie. I really enjoyed this talk. It was nice to see an example of integrated care, like delivered in practice. I want to learn from you if we can tap more on this global south and global north partnership. Like this effectiveness of this friendship bench has been established in a lot of African countries, and I was wondering if something similar can be tested in the UK here. Especially because I think a lot of ethnic minorities in the UK suffer from common mental disorders and are less likely to seek help. I think, especially I know of South Asians, I think they're one-third less likely to seek help than the general population. So I was wondering if you have if there are some similar trials happening in England or even in the States. And also, do you think, we always forget about, I think, UK when we're talking about global health. And I want to just know if similar trials are happening in these countries and if funders are really interested in targeting this. And maybe you can answer the first part of the question.
Thanks, Shalini. Yeah, I think there is, you've probably seen on the Friendship Bench website that an area of New York City has been using friendship benches, and they're different, they look very different, they're plastic benches, and they've been placing them in New York City, and a lot of people have been sitting on them, and people have been providing short-term therapy. I haven't seen anything in terms of evaluation yet. Also, the Canadians have a bench, I think it's called Hello Yellow, and so I think it's picking up. I was at a talk at the Science Gallery a couple of weeks ago, and they'd set up some benches. So I think that it's certainly becoming a very popular thought. We certainly know for young people that it's not necessarily a great model, because they don't visit primary care. So the Friendship Bench very much relies on the fact that the benches are placed within primary care. So there's that seamless passage through to safety, really. So if people have got a risky presentation, or the lay health worker is overburdened with the complexity, or the person needs antidepressants, then there's that easy passage through. But of course, young people don't use primary care in the same way. So we're experimenting with a different model at the moment in Zimbabwe. But in terms of this country, I think that it's really faith-based care that's been suggested as a possibility for settings for the Friendship Bench. And I think it was a little bit short-sighted. You know, we were involved in an application to one of the charities, but I think they were, very cautious because we were planning to put the benches in a faith-based organisation. They were very cautious, perhaps, about this whole link between the health service and religious faith. And it's a bit like, in many countries in Africa, there's split between the traditional healer and the modern health service, that there's a lot of fear. So I think that we do need to do some much more grassroots formative work to find out if people were going to use a Friendship Bench, where should it be sited here, and how are we going to also allow for that safety. So a project I'm working on in Liverpool, they're actually putting the benches in, this is for migrant asylum seekers and refugees, they're actually using agencies, social care agencies. So I think there are lots of possibilities, and we need to talk about them. Yeah. Thank you for your question.
Thank you very much. Okay, so we're moving to our last talk before the roundtable and the comment by Richard. And there will be drinks and nibbles at the end for those of you who want to stay. So my next speaker is Dr. Matthew Prina, who is going to shift to a new field. So we're moving to the aging field. Matthew.
So I'm going to start my talk by taking you back to my school days, maybe yours as well. But when I was in school, I had a wonderful teacher called Mrs. Green, who was absolutely obsessed with population pyramids. I learned so much about population pyramids during my school days. That's one of the only few things that I can remember about that. So there we go. I'm trying, and I think that in a way shaped my interest in aging. And I'm going to kind of give you an overview of the UK population in 1950. This is what we call a population pyramid because it resembles a pyramid. So you have more younger people at the bottom and fewer older adults. But if you move through time, you see that these has changed completely. And if you heard me talking about this before, you probably remember that I kind of say that this doesn't resemble a pyramid anymore. It looks more like a kebab, and then maybe we should start thinking about renaming it. But I think we're not quite ready to change the title yet, because if we keep moving up to the end of the century, it doesn't look like a kebab anymore. It looks more like a muffin or something like that. So we should probably just pause and start thinking about the meaning of this. But jokes apart, I think it's really important to highlight that the population structure in the UK has changed dramatically, and is changing dramatically. And that this phenomenon is not just happening in the UK, but it's happening across the world. So if you look at the percentage of people aged 60 and over across different countries and different time points, you'll find, for example, in Europe, if the pointer works, it might not. It does, but it's very faint. In Europe and North America, you see that the increase from 2000 to 2050 in the number of, or the percentage of people aged 60 and over is relatively gradual and steady. But in continents as Asia or Latin America, this increase is much more rapid and steep. And you can imagine the sort of repercussions that this kind of increase is going to have. If I was to ask you to write down the first thing that came to your mind, if I think of the word aging, I suspect a lot of you would probably write down dementia. And I think that's one of the things that I was asked to talk about during this talk. So I'm going to split my talk in two parts. The first one, I'm going to talk to you a bit more about dementia. And in the second one, I'm going to talk to you about healthy aging. So why is dementia important globally? Well, I've showed you that the population worldwide, we're living in an aging society, people are living longer. And we did this work back in 2015, showing the growth in number of people with dementia in millions in high-income countries and low- and middle-income countries. And if you take 2015 and you look at the bottom bar, so high-income countries, you'll find that between now and 2050, we estimate that there's going to be a doubling in the number of people with dementia. But if you look at low- and middle-income countries, you're going to have, it's already like almost 27 or 28 million, probably about now, you'll find that this number will triple by 2050. This evidence is based on a number of different studies, but if you look back in time, we don't really know much about the epidemiology of dementia in low- and middle-income countries. So this is a graph that shows before the work of 10-6 Dementia Research Group that Martin started back around 1998, that the majority of the prevalence studies of dementia, so the studies that assess the number of people living with dementia worldwide, were coming from North America, Western Europe, Australasia, and then there were pockets of studies here and there. but there wasn't really a lot of consistent research or evidence around estimates on number of people with dementia. And that's why the 10-6 Dementia Research Group started. And the name does stem from the fact that at the time, it was thought that even though 66% of the people with dementia live in low and middle income countries, only 10% of the research on dementia is carried out in those settings. So there's a large disparity, similar to what Craig showed for psychosis. So back then, Martin and colleagues started a number of population-based surveys to estimate the prevalence and also factors associated with dementia, but also other chronic conditions associated with aging in a number of different settings. So we have Mexico, Venezuela, Peru, Puerto Rico, Cuba, and Dominican Republic, India, and China. But before that work could start, there was a lot of piloting around coming up with a way of assessing dementia that was culturally, but also educationally less biased than the existing assessment of dementia. And that really was started in the pilot studies that were carried out between 1999 and 2002, so way before my time. And this then was developed into kind of the surveys that I showed you earlier, just before, across those sites. And those participants were then followed up 3 to 5 years later to look and explore risk factors associated with dementia. Between 2011 and 2014, we went back to 4 of these countries in Mexico, Peru, China, and Nigeria to carry out some mixed method studies looking specifically at the social and economic burden of care dependence. And finally, we are currently in the field, almost finalized, hopefully, and we're going to get a third wave of follow-up for those participants, and also at the same time a new recatchment of all this area, which means that we'll be able to assess trends in the prevalence of dementia across those settings. 10-6 data is open access. You can put the website down here. So if you're interested in working on epidemiological data or population-based data on dementia, go on the website. You can register and download all sorts of information around the protocols that we used, but also you can request on how to access the data. I'm not really going to present any findings from the 10-6. And part of my reasoning behind this is that there's been so much published around the 10-6 that I think the first starting point would be for you to go and have a look at the review that we published last year on the work of the 10-6 Dementia Research Group, where you're going to find a lot more findings. And I really want to have kind of focus heavily on the 10-6. What I've been doing more recently is that a couple of years ago, we were awarded an NIHR Global Health Group in dementia, which is led by Newcastle University, called DEPEC. And one of the main aims of this project was to try and establish some dementia risk reduction research in low and middle income countries. And this included also some piloting interventions. We're currently in the field doing some nutritional interventions in Malaysia, or piloting nutritional interventions in Malaysia. And this involved 4 countries. So we have Tanzania, we have India, Malaysia, and then it is led by Newcastle University, as I said earlier. The kind of my main role was around looking at, together with Blossom Stefan, who's kind of led this project, looking at risk prediction modeling for dementia. So you might have come across risk prediction modeling if you're familiar with cardiovascular diseases. So what is a risk prediction model is when you give or predict the risk of developing a certain condition given a number of factors that the person might have. And it's been used quite a lot in cardiovascular diseases, I was saying, but also in surgery and other fields. For dementia, is a relatively novel field, so there's been, however, already over 20 different dementia risk prediction models that have been described with variable discriminative and predictive ability. The main problem, or one of the main limitations of all those studies, that theoretically, when you have a risk prediction model that you develop in one setting, you should always look at how generalizable that prediction model is. So you should try and use a second cohort to validate it. And if you look at majority of those 20 risk prediction models, there hasn't really been many external validations. So most of them are developed, left in the cohort, and that's about it. So we thought that it would be actually a good idea to try and see whether those models could be applied into different settings, and specifically in low and middle income countries. We were able then to use a 1066 study, and particularly 5 different models that were identified from this review, including those names. I actually cannot remember what each one of them stands for because they're a bit of a mouthful. But that's not really what you need to worry about. So what we did was to look at each one of them and then apply them to our 1066 prevalence and incidence study. So this graph is quite confusing, and I did have a conversation with Barbara earlier on that she doesn't really like really complex graphs and studies, so I'll try and guide you through it. But effectively, the important message here is that you have, let's look at the CADE, which is one of the risk prediction models that was developed. On the left side, you have what we call the C-statistics. And the C-statistics is just basically a measure that goes from 0 to 1 that assess how good or how well that model predicts a specific outcome, in this case, dementia. And that's the C-statistic for that particular measure. So in the original cohort, when it was developed, that was 0.77, which is considered a good fit. So anything above 0.65, I would say, is probably quite good. And so we applied that across all the sites of the 1066, so China, Cuba, Dominican Republic, Peru, Puerto Rico, Mexico, and Venezuela. And what you see is that the prediction, the risk prediction for all this model is much lower compared to the original cohort. And similar thing you'll find here for this other risk prediction model. But then we found that at least 3, I'm only presenting 2 here, had a relatively good fit. So the C-statistics was very similar in high-income countries compared to low- and middle-income countries. And that, for me, was really quite reassuring because although 2 of the models showed poor performance, 3 of the models showed comparable performance in our settings compared to high-income countries. And I just put here a list of the kind of items that those risk prediction models would have. Some of them are quite, as you can see, there's a very long list of factors, and others are much more simple, so they might focus only on very specific risk factors. But why do you think it's important to use those kind of models? Well, I think one of the key reasons is that because we could apply some interventions to try and delay the onset of dementia. And on that respect, WHO earlier this year published some guidelines on risk reduction of cognitive decline and dementia. And I think the take-home message was that there were at least 4 strong recommendations that were made around physical activity, smoking, hypertension, and diabetes. And those are things that could be targeted to delay the onset of dementia. Do keep in mind, though, that the evidence around dementia risk factors is really quite still fragmented. So if you take a longitudinal study, an epidemiological study, you find that a lot of factors are possibly associated with dementia. But when you start converting and moving on from epidemiology to interventional studies, a lot of those factors don't seem to be as potent. And part of the reason for that, I suppose, is because interventional studies tend to be shorter, and a lot of the changes with dementia might have started many years prior to when people are actually recruited into these intervention studies. Last couple of slides on dementia. Recently, last year, the Alzheimer's International published a very nice report, so if you haven't looked at it, I would encourage you to go and look at it, around attitudes to dementia. It was led by researchers at the London School of Economics. And what they did is that they interviewed or did surveys with almost 70,000 people from 155 countries. And I'm not really going into details of this work because obviously I wasn't involved in it. But for me, one of the staggering figure was the fact that 2 in 3 people thought that dementia was caused by normal aging. And for me, that was quite astonishing because I think we are clear that dementia is not part of normal aging, but majority of people still think that dementia is inevitable if you live long enough. And I think hopefully that is not the case. And that's why the last part of my talk is going to focus on what we should also try and achieve, which is healthy aging. So what is healthy aging? I think if you asked people in the audiences, you all come up with slightly different answers. And I think that is a major problem that is hindered somehow the advancement of this field. Thankfully, WHO came up with a very nice definition in 2015, defining healthy aging as the process of developing and maintaining the functional ability that enables well-being in older age. Effectively, what it is made by three different components. Intrinsic capacity, which includes both mental and physical components, functional ability, and then the environment. And the interaction between these is what makes healthy aging. However, it's very easy to have a theoretical framework, but when you try to operationalize it, or moving from a theoretical framework into something more that you can actually measure in population studies, it becomes quite difficult. We published this work, we kind of did a review back in 2013, when healthy aging was probably not as popular as it is now. And we found back then that there were already over 100 operational definitions of healthy aging. So you can imagine that if you're starting out and you're trying to apply, you say, like, which one is the best way to kind of operationalize healthy aging? You're hitting a stumbling block because you don't know where to start. And I think WHO is working quite hard to actually try and come up with a kind of more comprehensive operational measure, which hopefully will be launched next year as part of the Global Aging report that will be launched next October. We also, one of our main interests has been around understanding what factors are associated with healthy aging. And 2 or 3 years ago, or maybe 4 years ago, we started this work. And we published this report a couple of years ago. And this was an assessment of all the factors associated, modifiable factors associated with healthy aging. Those of you who know me know that I'm quite happy. I love systematic reviews. I do a lot of them, and I'm definitely quite keen on them. But I think this was probably the only exercise that almost put me off systematic reviews, because what we did was to screen over 93,000 papers, text and abstracts. So that was a huge exercise in manpower, and it took a very long time. And I really thank those people who actually went through the screening process, and it wasn't me, thankfully. But I think one of the staggering figures of this report that was highlighted again is that the majority of study and evidence was coming once again only from high-income countries. So majority of factors that had, or most of the studies were in North America, Australasia, Western Europe, and then you had a pocket of study. I think there was one study or 2 studies in China and 1 in Nigeria. I don't know why Nigeria is selected instead of Nigeria, but that's the way it is. And I think that really shed light into the fact that this is really what the dementia field was 10, 15 years ago, and it's something that hopefully in the future will change. This project was part of a larger European grant that was funded, called ATLOS, Aging Trajectories of Health, Longitudinal Opportunities and Synergies, which is a really long name. But the main aim of this project, apart from understanding factors associated with healthy aging, was to come up with and assess patterns of healthy aging trajectories. And the way we did this was to take as many cohorts we had access to. So in this case, we had 18 different cohorts that were carried out across the world. So some were based in low and middle income countries, some were based in high income countries. And really what we wanted to look at was to assess how do aging trajectories differ across countries or cohorts, and what factors affect changes in these trajectories. How do we define healthy aging? Well, we decided to come up with a new measure. I know that this is not really helping the field, but I thought it was one of the first measures that actually map onto the WHO definition of healthy aging based on intrinsic capacity and functional ability. So we had 41 items related to those intrinsic capacity and functional ability. And using that, using item responsibility theory, we generated this health status metric that would then rescale from 0 to 100. 100 being you're aging as healthily as you can, 0 being you're not aging as well. And really, a couple of slides here. I'm just going to show you some findings that we just submitted actually recently. So for this particular purpose, I'm going to show you the work done on 8 cohorts. And the only reason why we picked 8 cohorts is because they are the only ones that had at least 3 waves. And when you're looking at trajectories, you need at least 3 time points in order to do them. But what I wanted to show you is the fact that, so for example, these are all the studies, this is baseline for all the studies, and these are the scores. And the cohort with the highest healthy aging scores was the Japanese cohort, J-star, and the Mexican study was actually the only study that we had that was based on middle-income countries, was the one with the lowest scores. But I think for me, this was, it was interesting, but it wasn't majorly groundbreaking. What I thought was much more interesting was the fact that when you start looking at factors that are associated with these trajectories, that education and wealth, we're also looking at other factors, but I'm only going to show you education and wealth, have very clear patterns across all of the studies. So if you're comparing the scores in people who have middle education versus low education and high education versus low education, you find similar patterns across them all. And equally, if you're looking at different quintiles of wealth, you'll find that all this very nice shaped dose response, where if you are more wealthy, you tend to have higher healthy aging scores. And this is after adjustment for a lot of different factors. For me, though, the key factor here, if you look at the Mexican and healthy aging studies, so the only study based in low middle income countries, those differences are there, but they're not as large as the HRS, which is based in the US, or ELSA, which is based in the UK, which I think does highlight the fact that maybe health inequalities in high income countries is also something that we should really pay more attention to. So my last slide here is about some of the kind of pending issues, among many, many others. I couldn't really, I think this was a kind of stream of consciousness of things that could come to my mind. But I think it's still really early days for healthy aging. It's a field that is moving quite rapidly, but I think there's so many operationalization problems that are really hindering the advancement of this field. I haven't really talked much about other mental health problems, particularly common mental disorders, but also suicide in older age, which I think are still massively under-researched in low and middle-income countries, both epidemiologically but also interventionally. I'm glad to see that the last few years, particularly last year, have seen an increased funding on frailty and multimorbidity. Some of you have touched upon it earlier today, and I think this will hopefully lead to kind of more effective interventions that are also culturally appropriate. I'm really not an expert on health systems, social care, or health costs, but I think this is going to be a major problem that aging societies are going to face. Costs associated with aging society are going to increase dramatically. And do we need to really start rethinking possibly around how health systems and social care and how we deal with aging populations? And finally, I'm glad that Andrea raised it earlier, but I think it's really also very important to start thinking about a life course perspective. So I work in aging, but I'm also really interested in the effect of early exposures in life, but also early adulthood, midlife. And I think it's something that hopefully we will do a lot more in the future, and also in low and middle income countries, because I think the majority of evidence in life course epidemiology at the moment does stem from high income countries where the data is available. So I'm just hoping that next time you're going to have a kebab or a muffin, you're going to think about population aging. So that's me. Thank you.